Good day, everyone, and welcome to today's program, Lessons Learned, Tobacco Cessation, and Health Systems Change. At this time, all participants are in a listen-only mode. You may ask a question at any time during today's program by using the Q&A pod on the right-hand side of your screen. Please note this call is being recorded. It is now my pleasure to turn today's program over to Ann DiGiulio. Please go ahead.
Thank you, Priscilla, and thank you, everyone, for joining today's webinar, Lessons Learned in Tobacco Cessation and Health Systems Change. As Priscilla mentioned, please feel free to ask a question at any time using the Q&A pod. We will answer questions at the end, but if you're going to miss one, forget it. Please feel free to type it in as the presentation is going on. I'd like to introduce you to our speakers. I will be speaking briefly at the beginning. I'm the manager of lung health policy here at the American Lung Association. I run our tobacco cessation policy project. As part of that, I manage 2 federal grants, one collecting tobacco cessation coverage data in state Medicaid programs, and the other one offering technical assistance around tobacco cessation and coverage issues, and then tobacco cessation and health systems change. So please feel free to give us a call if you've got any questions. And then I'm very honored today to be joined by 2 of our speakers. First, we've got Joy Luther from the Oklahoma Hospital Association. She's been working in tobacco control for over 17 years and has been working in public health for over 40 years and is going to talk to us a little bit about the work that the Oklahoma Hospital Association has done in with health systems change in Oklahoma, obviously. And then we've got Megan Whittick, who's with Clearways Minnesota. She manages the organization's health systems change initiative, and she's got over 14 years of experience in tobacco control. And then I just want to give you a quick overview of what we're going to be doing today. I'm going to give a brief introduction, setting the stage of what we're going to be talking about. Then we're going to hear from Joy talking about Oklahoma, and then Megan talking about Minnesota, and then we're going to have a few minutes for question and answer at the end. So just to make sure we're all on the same page before we get started, we want to quickly talk about what a comprehensive tobacco cessation benefit is. So as defined by the Treating Tobacco Use and Dependence, the 2008 update, a comprehensive benefit is 7 medications, which are the 5 nicotine replacements, the gum, patch, inhaler, nasal spray, and lozenge, and then bupropion, also known as Zyban, or varenicline, also known as Chantix. Additionally, there are the 3 different types of counseling: individual counseling, which is your traditional face-to-face counseling; group counseling, which can sometimes be a class counseling; and then phone counseling, which is obviously over the phone. In addition to what the comprehensive benefit is, we also find a number of barriers to access to care in all different settings. So in those include cost sharing, such as copays, prior authorization, stepped care therapy, duration limits, annual limits, dollar limits, all of them that you can see up there. And now, why health systems change? Why are we talking about this today? So there are a couple reasons, which I'm going to go through in a little bit more detail quickly, namely that smokers want to quit, and that there are also some financial incentives that are impacting both providers and hospitals to try to encourage patients to quit, besides that it's good for everybody's health and is a good idea. So we do know that smokers want to quit. A recent MMWR back in January showed that over 2/3 of smokers want to quit. However, only about half of them received advice from a health professional and made a quit attempt. And unfortunately, fewer than 1 in 10 smokers quit successfully. In Medicaid, this problem is also known. There was an article in Health Affairs a couple years ago that showed that only 10% of current smokers are receiving a prescription for tobacco cessation medication. So clearly smokers want to quit, but there's a lack of actually doing the quitting. Additionally, there are some external forces that are happening that are encouraging smokers, encouraging health systems change around tobacco cessation. Obviously, tobacco-caused disease is costly in terms of both lives and money, and there are a number of external forces driving systems change. There are a number of quality measures that are asking providers and hospitals to take more of a financial risk in the health and well-being of their patients. There's the HEDIS quality measures, there's the Joint Commission measures that are for hospitals that are going into place, and then 2017 is the first performance year for macro payments for payment year 2019. So we do know that value and payments are being tied closer and closer to each other. So just as there's some reasons that tobacco cessation and health systems change are important. With that, I'm going to turn it over to Joy, and we have had a couple of questions come in already, and I just want to say we are recording the webinar, and we can send you a copy of the slides if you want them. So with that, I'm going to turn it over to Joy, and I will advance the slides. Joy?
Thank you so much, Ann. I'm delighted to be here today with all of you who are participating. I'm going to talk a little bit about what we're doing at the Oklahoma Hospital Association. We have a couple of programs, but the one I'm going to visit with you about today is Hospitals Helping Patients Quit, Advancing Tobacco Treatment. Let's see. There we go. So one of the reasons that we're doing this through the Hospital Association is that we have a larger membership of hospitals throughout our state. We have about 135 hospitals, of which 85% are members. So it gives us the ability to actually be able to interact and access leadership in those hospitals through our board of directors, through various committees, and through a lot of the advocacy work that we do. Traditionally, associations do a lot of legislative advocacy for hospitals, but there's also an expanding role for quality and clinical initiatives, and so this falls under that. We're sort of uniquely positioned because of that, and we have a good reputation with our hospitals, so that allows us better access. We began our program in 2009. We are funded by the Oklahoma Tobacco Settlement Endowment Trust. That is a trust that was developed from the Master Settlement Agreement dollars back in the late 90s. And the Tobacco Settlement Trust, we call it TSET, was formed around the year 2000, 2001, so that those dollars go into a trust fund to build the principal, and all of the earnings pay for a myriad of programs and initiatives in our state, including research, prevention, treatment, and education. We have 3.5 staff members, myself as manager, 2 coordinators, and a half-time assistant. We currently have touched about 50 hospitals and health systems statewide, and by measuring the number of referrals to our Oklahoma Tobacco Helpline, which is also funded by TSET, we're able to track and understand how many people that we're able to impact. So from October 2010 through March of this year, the referrals to the Oklahoma Tobacco Helpline have totaled over 20,000, and 50% of those are electronic referrals now. We have about a 29% acceptance rate for services, and 35% of those who receive counseling and pharmacotherapy remain quit at 7 months, which is roughly the same equivalent at 1 year. So what we do is we're looking at very comprehensive system changes. We want to impact a tobacco-free culture. So we look at policy issues and how to have a tobacco-free policy campus-wide for our hospitals. So that's inside and out. We also look at policy in terms of health benefits for employees so that they're able to receive tobacco cessation counseling. And we also focus on not just patients, but their family members as well as employees. So we're looking at a sustainable system change that's embedded in the clinical process in the hospital and for the affiliated clinics with that health system. So we embed the clinical process flow based upon the evidence-based clinical guidelines, the 5 A's, and then workflow is integrated into the clinical protocol via the electronic medical record, and ultimately with some of our hospitals we're doing electronic referrals. Anne, I want to ask you a quick question. I'm sorry to interrupt, but
No worries.
I'm thinking that some of my slides are not here.
Oh, no.
So I'm going to go ahead and talk about those in between very quickly. So if you all will bear with me for just a moment.
Okay, and we'll send out the complete slides, and Joy, I'll work with you to make sure we get all of them, okay?
Okay, very good. Hospital is an appropriate time to be working with patients because we want to treat the person wholly. We don't want to just use strictly what has traditionally been the medical model to diagnose a problem and just treat that. Oftentimes the illnesses that they're hospitalized for are tobacco-related, so we want to deal with the etiology of those illnesses. The majority of tobacco users visit a health system annually. This is a teachable moment. They're motivated due to hospitalization. And also the tobacco-free campus and culture supports that cessation. The opportunity for positive experience with adequate dosed medication and supportive treatment is a key factor in success. The other reason hospitals are very important, and clinics, and Ann mentioned this just a moment ago, is because of the quality measures that are now expected to be used in certain areas. The Joint Commission quality measures, as many of you may be aware of, are still optional, but some hospitals are adopting those. In addition to that, CMS has a requirement for inpatient behavioral health to be using the tobacco measures, which is screening and then providing treatment and referring. And then also meaningful use through the electronic medical record has been a requirement. So we capitalize on that. So while embedding the clinical workflow, yeah, we're missing some slides here. We include the 5 A's: ask, advise, assess, assist, and arrange. And the workflow is such that when a person comes into the hospital or clinic, they are automatically screened with a series of questions. We're expanding that so it's not just asking them, do you smoke, but we want to know if they use any form of tobacco, what kind, how much, do they live with someone who smokes, have they attempted to make quits in the past, and then based upon that, a yes to any of those questions automatically sends a referral to a designated staff. Some hospitals use nursing staff, some hospitals use respiratory therapy, some use social work staff, but that referral is critical. It automatically goes to that staff person who then goes in to do the bedside visit. At that point, then they advise the patient and tying it to their medical issues while they're in the hospital. So even say, for example, an orthopedic patient, we want to talk with them about the fact that quitting smoking or any tobacco use will help their healing. It will reduce complications if they're having surgery and those sorts of things. And then we assess their readiness to quit. So through motivational interviewing and their level of quitting, then we make sure that we provide them with adequate nicotine replacement therapy as long as it's not contraindicated. And that's a key element because traditionally physicians do not adequately dose that in the hospital setting. So we do a lot of education with staff around all of these issues, but particularly pharmacotherapy, so that we make sure that they have an adequate amount of NRT. That way, if we're regulating their cravings, they don't want to get up with their IV pole and walk out the front door to smoke, which actually does happen in some hospitals. So if we're making them comfortable, whether or not we do a referral then to the helpline for coaching and that sort of thing and follow-up, we're still seeing some success in one form or another. and it may be the first time that they have a successful experience with adequate nicotine replacement therapy. So we also go back and reassess for their comfort with the medication, and then we make a referral to the helpline. With some hospitals that are not yet fully developed in their electronic medical record, we may actually make a paper fax referral. But for some of our larger systems, we actually have embedded it into the EMR so that there is a referral electronically to our helpline. That could be either a batched file, it could be an electronic fax, or it could be a direct messaging or a direct referral through HL7 technology. So I want to talk about a couple of case studies here. Before I talk about the Chickasaw Nation, I want to mention Integris Health, which was the first system we worked with. Beginning in 2010, they were a system-wide implementation. They began their referrals in October of 2010. It took them 18 months to implement, and it required a full-time coordinator in the hospital to help coordinate all of this with our assistance and our consultation. But as of March of 2017, that system has made nearly 10,500 referrals to the helpline, almost 8,000 inpatient, 2,000 outpatient, and 261 employees, and also 86 community health members. The Chickasaw Nation we worked with, again, over a period of 18 months. They were great to work with. They have the second largest Native American population in terms of numbers, and nearly 300,000 are in our state, which is about 9% of our population. We went to them and started working on developing with the EMR that they have, which is called RPMS, Resource and Patient Management System. And they launched in November of 2014 with electronic referrals. They also have 4 clinics that launched in February of 2015. And as of this time, they've made over 2,000 referrals, which includes their clinic and their hospital. You can see the numbers there. They adapted a workaround, which is an SFTP secure file transfer protocol. They batch the referrals that are sent to the quit line, they encrypt them, and then they drag and drop them to the server for the helpline. This is sort of like not the preferred technology at this point, but it is a beginning step. The outcome reports come back to the hospital via that SFTP encrypted server process, so that they know what's happened with those patients, and they know what the success rate is with those patients. This is an exciting project that we have with the University of Oklahoma Medical Center. The Children's Hospital came to TSET and then to us and wanted to do this very process in their perinatal and neonatal program. We were very excited at that prospect. They are a level 3 NICU with 90 beds. They receive infants statewide as well as from Kansas, and they have a very large Medicaid population. The whole purpose of this is to develop a system to treat and refer their caretakers, be they parents, guardians, or whoever, so that when that infant is discharged from the hospital back to the community, they're not going into a home where there's secondhand smoke. This is done because we want to improve their post-discharge healing, which is very important. This, too, has required a coordinator and a half-time social worker in the hospital. It's a shared cost with our program. They launched in April in the NICU, so they are screening neonatal parents and caretakers using the best practice. It was embedded in their electronic medical record as an electronic fax. They use crib notes, which is the EMR. And this process is different. We don't have outcome reports come back because those children are released back into the community, and so there's no need for it to go into the record. It's also very difficult to get it back into the record because the record is the patient, which is the child, and not the parent. But at this point, they have screened nearly 800 parents and caretakers. 85% of those babies that are admitted have had parents and caretakers that were screened for tobacco use, and of those, 49% received cessation services by the NICU staff and were referred to our helpline. They have now expanded that to the prenatal diagnostic center, which is the high-risk pregnant patients. They've screened 38 OB patients, and 27 were referred to the helpline. We're very excited about that. And then we had a request for this next fiscal year, which begins in July, to expand the process to the pediatric cardiothoracic surgery area and their Oklahoma Infant Transition Center, which is the center that helps these babies transition. Because of every system being so different, our motto is, when you've worked with one system, you've worked with one system. So it's very, very different. On lessons learned, first I want to say tobacco treatment in healthcare settings has to be embedded in the process. The clinical flow has to be there in that electronic medical record in the screening questions. It's very important that we provide FDA-approved pharmacotherapy with appropriate dosing, electronic referrals to quit lines, preferably through direct messaging is key, and in most cases, returning those outcome reports from quit lines to the patient record is essential, particularly in systems, for example, Mercy Health in Oklahoma. The system was embedded in their EMR for both hospitals and all of their clinics, which is over 60 clinics, so that whether they go in the hospital or they go to their primary care provider in their office, that patient chart has that information as to the success of their quitting attempts. Large system implementation requires internal system resources. We start with talking to leadership, CEOs, COOs. We have to get buy-off from all of those folks, the clinical folks, the chief medical officers, the chief nursing officers, and then it's really important for them to have accountable administrative oversight. So we develop a multidisciplinary implementation committee. In the large systems, we recommend they have a full-time coordinator in-house, and then we want to engage the IT support and expertise. In addition to that, permanent health changes or permanent changes in the health systems requires a very focused effort with funding and dedicated staff to consult. That would be what we do. Provider associations are very effective, as I mentioned before. Support to health systems requires expertise in best practice, in technology and funding. Resources are essential, staffing resources inside the system as well as financial support and external expertise. The greatest impact is through larger multi-service health systems, including their urban and rural providers, but we also work very closely with small hospitals. We have some hospitals that are 25-bed acute care hospitals in the rural area, and those too can be very impacting. Our biggest lesson is patience, patience, patience. This work takes time, and we have learned with some of the larger systems that it really depends. Some of them are 18 months, some have been as long as 5 years. There's the rest of the slides. They're out of order. So
I'm so sorry, Joy. I don't know how that happened, but I promise we will get everybody the appropriate slides in the right order after the webinar is over. So I apologize again.
At least you have the information so you can see here. I'm just going to go on to the very last slide. So this is our contact information. Eric Finley and Jennifer Royston are our systems coordinators. They do a lot of in the community consultation, working one-on-one with hospital staff to do this, as well as the clinics. We also have worked with some behavioral health units, both inpatient and outpatient, and you have email and phone there if you need to contact me, and I hope I'm within my time limit.
Yeah, thank you so much, Joy. I think we may have had some extra slides. I don't know what happened, but I'm going to now turn it over to Megan and get to Megan's slides. There we go. Megan, are you on?
I am on. Thank you so much.
Great. Fingers crossed that your slides are a little bit better.
I thought you did a great job maneuvering through those, Joy, with or without your slides, and I can do the same thing if something's going on. So no big deal.
Sorry about this.
So thank you, Anne and Joy. I really appreciate the opportunity to share with all of you what we are working on in Minnesota on our health systems change initiative. So I am going to, here we go. I'm going to start by providing a few minutes on sharing some of the brief, review on our approach to health systems change. As a part of that, I'm going to give an update on our health systems change grants as well as our capacity building project. But for those of you who are on the line and are not familiar with Clearways, Minnesota, we are an independent nonprofit organization. We were founded in 1998 with 3% of the state tobacco settlement dollars, and we were established as a limited lifetime organization. And our mission is to reduce the harm of tobacco and secondhand smoke through research, action, and collaboration. And we have multiple departments within our organizations to help us reach that mission. This includes a research department, we have community development doing a lot of community work, a public affairs doing some policy work, as well as a communications department and our cessation department. And our health systems change initiative falls under our cessation policy work in the cessation department. The way we are defining health systems change is that it's a sustainable integrated solution at the organization level that supports clinicians and health systems to address tobacco use consistently and effectively with patients. And we know that health systems play a key role in providing this evidence-based care. And when we're referring to health systems, we are referring to a variety of health systems, everything from a smaller community health center or FQHC to the larger integrated health systems with multiple clinics and hospital settings. We have three main areas of our health systems change work and to support these efforts. And I'm going to, again, highlight some of the work from our systems change grants as well as our capacity building initiative. I'm not going to spend time today going over our policy initiative, but for those of you who may not be familiar with what that work is, the goal of that is to elevate tobacco as a priority among the state healthcare reform programs. So thinking about healthcare homes and other state healthcare reform programs that we have here in Minnesota, we're really looking to elevate tobacco among those programs as well. So for our health systems change grants, the purpose of these grants is really to make the delivery of tobacco treatment a standard practice of care and to fully integrate systems change strategies that can be sustained over time. So these are two-year projects, and we have funded 2 rounds of grants. The fiscal year 2014 grantees ended last April, and then the fiscal year 2015 grantees ended just last month of this year. As a part of our granting initiative, we have worked with an external evaluator to conduct a process evaluation of these projects. And there are several core strategies that have been found to be successful in facilitating change that the grantees have implemented as part of their work. And I'm going to take just a few minutes to share some of those examples with you and highlight some of the successes from each of the grantees. First, for the fiscal year 2014 grant, HCMC was very successful in modifying their electronic health record to incorporate multiple referral options into the EHR. This included the Call It Quits referral program. That referral program is supported by Minnesota Tobacco Quit Lines, which is a collaborative among Minnesota's major health plans and Clearways Minnesota. And this program enables healthcare providers to use a single form and fax number to refer patients to Quit Line support. Hennepin County Medical Center was able to register all of their 47 ambulatory care clinics with this program and then get that form embedded within their EHR that would then auto-populate with the patient, provider, and clinic information, and then it's faxed directly to the program from the EHR. This greatly streamlined their processes for the program and referral process, as well as embedding a number of other referral options into their EHR so that providers had a number of referral options to choose from for their patients, depending on where the patient was at within that quitting process. Mille Lacs Band of Ojibwe was highly successful in taking a team approach to their work, where they included monthly team meetings with key personnel to help track and coordinate all of the commercial tobacco control and prevention efforts that were happening within the reservation. So at the time that they embedded their health systems change work, they had a number of other initiatives going on, and they brought all those coordinators together to help coordinate all those efforts, including a clinic champion, and the clinic champion was an RN who was from the main clinic on the reservation, and that person was really successful in providing information back to the tobacco team to further the systems change efforts, as well as helping to elevate tobacco as a priority among the staff and providers in the clinic setting. And then CentraCare Health was able to implement a pilot project at their Big Lake Clinic, which involved the key stakeholders as well as all of the staff and providers from the clinic. During that pilot project, they were able to track the patient tobacco use rates, and during that 10-month period, they saw a decrease in the tobacco use rates among patients that went from 21% to 17%. So this was a huge success for Big Lake and was largely contributed to the fact that they had a really strong clinic champion as well as a strong provider champion that helped them through that pilot project. For the fiscal year 2015 grantees, Essentia Health was very successful in building internal support to further their systems change efforts. Through collaborating with another internal department within Essentia, they have been able to get several new tobacco treatment specialists located throughout their clinics. So as a part of that, they now have 28 tobacco treatment specialists located throughout 27 different sites within Minnesota that offer face-to-face counseling. And since they began their rollout of their internal referral program, they've been able to track those referral rates on a monthly basis. And I know the graph is a little small, but as you can see, they continue to refer a large number of patients each month. So far they have referred over 2,900 patients to the tobacco treatment specialists that they have located throughout their health system. And they've also been able to track of those patients which are now how many are former tobacco users, as indicated within their EHR. And they've been able to report this information and share this back with staff and providers to really help improve and increase the referral process. And then Apple Tree Dental also rolled out their initiative last May. They started by making modifications to their electronic health records so that they were also able to track their efforts. And when they did their rollout, they embedded their new protocols and standard operating procedures throughout the 6 main clinics that they have located throughout Minnesota, and this map shows where some of those clinics are located. They rolled this out by training all of the staff and providers at each of the 6 main clinics, and then again tracking their efforts. And as part of tracking their efforts, they've been able to assess over 9,000 patients as to whether or not they use tobacco. They've been able to conduct a tobacco intervention with almost 1,000 tobacco users. And they've also been able to track a number of referral processes. So again, this has been, they've also been very successful in tracking their efforts and then sharing that back with staff and providers as well. As a part of our process evaluation, we've also been able to identify what some of those key challenges are that the grantees faced during their work, that closely aligns with some of the solutions and lessons learned that they've shared as well. So I just want to highlight a few of those for you today. One is implementing those electronic health records, and that can certainly be a challenge to make those modifications or changes. This is something that all the grantees had done to some extent. And so certainly working closely with the IT staff from the very beginning was found to be very helpful and an important lesson learned, as well as piloting the EHR elements to get some immediate feedback, and so then being able to really identify what was working or what may not have been working within the EHR. Also can be challenged was, of course, reaching all of the staff, including new staff. This is something that, in particular, Hennepin County Medical Center, for example, found to be a challenge because they had a number of sites that they were working with and trying to get information out to all the providers and staff. So working with 47 ambulatory care clinics, they need to find a way to do this. So they ended up utilizing multiple forms of communication and repeating those same forms of communication, not just relying on one form or one announcement and that sort of thing. They also utilized the new employee orientations by incorporating their training into the new employee orientation, so new staff would also be trained on their new protocols and procedures. And then lack of funding for training staff and prioritizing systems change work, of course, is a challenge as well. This was found, one of the grantees really found this to be very helpful by utilizing current resources and processes. So I shared how Essentia was successful in collaborating with another department within the health system. In addition, a variety of other grantees utilized various initiatives or other trainings that were happening within the health systems and leveraging tobacco onto those trainings to really help elevate tobacco as a priority. And then, of course, again, sharing the data and tracking the information and sharing that and getting that back to leadership is a way to really help prioritize tobacco as an important part of what the health system is doing. And of course, one of the other things around the work, we worked with our evaluator and with the grantees to help identify what were some of those key strategies that sustained this work over time. And we asked the grantees from the very beginning of their projects to incorporate and think about those strategies that would sustain this work once the funding has ended. And so we found that many of the same strategies that facilitated change also sustained this work over time. So again, really including thinking about maintaining those strong working relationships between departments and with leadership, and bringing those folks on early on into the work was really important to sustain the efforts. Thinking about the reporting mechanism and quality improvement, what information would be helpful to get back to staff and providers and to leadership to really help improve these processes. And then thinking about those other system level priorities or initiatives that were happening and how can tobacco get leveraged onto those. So again, some of those very same facilitators of change also facilitated sustaining the work. As a part of our process evaluation, we work closely with the evaluator as well as with the grantees to create these case studies. And the case studies highlight the strategies, successes, challenges, and lessons learned from each of the 3 grantees that ended in April of 2016. So we have 3 case studies finalized. We're going to be working closely with the evaluator and with Apple Tree Dental and Essentia Health so that we can get the case studies completed for those projects now that they have ended. And you can go to the website on the link that's shown here to view these case studies. They are PDFs that you can download off of our website. And we've been able to use this as a great tool. These have been a wonderful tool to really highlight some of the successes and lessons learned and getting that information out there to within our Minnesota network and nationally. So I'm pleased to be able to share these case studies with you today. All right, so I'm going to move on and shift now from our granting initiative to our capacity building project. The goal of our capacity building initiative was really to expand our reach beyond just our health systems change grantees, and also to think about how could we work with health systems serving patients with high tobacco use rates. We knew that many of the health systems that were serving populations with high tobacco use rates were not necessarily ready to take that comprehensive approach to systems change, but how could we build our capacity and move them along that continuum of health systems change. So we began this project with a planning phase. We had 6 months of a planning phase, and then we are now finishing up year 1 of this work. And we will begin year 2 in July. So the project is, will be ending at the end of year 2, so at the end of June 2018. For this initiative, we are partnering with the Institute for Clinical Systems Improvement, or ICSI, which is a nonprofit organization, and they're located in Minnesota, and they provide quality improvement initiatives for clinics and health systems. They work with health systems and clinics to help identify what are their quality improvement goals, and then how do they reach those goals. Okay, excuse me, sorry, just 1 second, I lost my mouse. There it is. All right, so I want to just take a few minutes and just highlight fairly quickly what some of those year 1 activities look like for this capacity building project, just to give you a snapshot of what this project is. First, we have our interest group. This interest group meets around quarterly, and it includes a variety of individuals. The group started from our advisory group that we had during the planning phase of this project, and since that time, we've brought on a number of several new participants into the group. And as you can see, there's a variety of participants representing various organizations within Minnesota, so health systems and clinics, but also the health plans as well as statewide organizations and statewide agencies, such as the Department of Health and Human Services and Minnesota Department of Health. The purpose of this group is to come together to share insights with one another, to help network, to help discuss what are some of the questions and issues around health systems change, and to really help inform some of these capacity building initiatives that we've had throughout the project. The next, we also had a rally around health systems change. In November of last year, we held our health systems change rally, which had almost 100 participants attend. The purpose of this event was to share what is health systems change and why is it important. Dr. Michael Fiore from the University of Wisconsin came and did a very informational and energizing keynote presentation. We also had a panel of health systems serving different populations to discuss how they've advanced change efforts within their organization to better address tobacco use, as well as a panel of providers to help discuss champions and how to support champions in this work. Many of the participants agreed that there was something they were really going to be able to take back and learn from this event, so it was a very successful event. And following that event, we then had 2 regional workshops. And the purpose of these workshops was to provide some of the practical and real-world examples around how to conduct and think about some of the initiatives that really could bring health systems to that next level of health systems change. And so we really wanted to focus on serving the needs of the clinics and other health systems in Minnesota at these workshops. So they were smaller in scope with a little bit more specific focus. Some of that information that was shared, we brought experts in to share information on NRT, scripting, and quality improvement initiatives. And between the 2 workshops, we had almost 50 participants. And that, again, they were very successful workshops, and participants really felt like they were going to be able to bring something back to their organization. Another newer initiative that ICSI has been working on as a part of this work over the past couple of months is providing a coaching opportunity to 3 organizations to help them build their capacity to assess and address tobacco use. This includes with Entira Family Clinics, which is located in St. Paul, Tri-County Healthcare, located in Wadena, and then the American Indian Cancer Foundation. With Entira and Tri-County, working with those clinics and health systems, what they're going in and helping to elevate tobacco as a priority within the health system, creating standard workflows, addressing those workflows, thinking about ways to support providers and what their providers need to do this work, really essentially meeting the clinics where they are at and helping them identify what their systems change goals are within the clinic setting and then helping them reach those goals. With the American Indian Cancer Foundation, this is a little bit different because the American Indian Cancer Foundation is providing support to Native American clinics on tobacco health systems change efforts. And so what ICSI is doing is they're going into the ACAF and they're using a coach-the-coach model with the ACAF staff. So providing training to the ACAF staff, shadowing opportunity and feedback to build their staff capacity to then engage and coach the Native American clinics that they're working with. So these are really exciting, all three of these are really exciting opportunities, and we're really looking forward to sharing more stories and lessons learned from these opportunities in the near future. I want to end by just sharing that one of the things we look to do as a part of our capacity building initiative is to communicate all of the work that we're doing within Minnesota in this effort. So ICSI developed a website which highlights the past and upcoming activities that we're having. On this site, folks can also join the electronic newsletter and as well as link to a variety of other tools and resources. And we're continually building on those tools and resources. We wanted to create a central location where information could be shared. And we know that there's a variety of information both from Minnesota as well as other states. So we're continuing to build on this, and I actually have a number of resources to add to this website now that I got back from the national conference in Austin. So we're really looking to keep building on this information. And as I mentioned, the electronic newsletter, this is something that we're putting out there every other month, and it's going out to over 170 participants. The idea here is we want to share information on, again, some of the upcoming or past activities, as well as resources that are out there to share with folks. I mentioned one of the goals of our capacity building project is to have a greater reach, and so I just want to share this with you. We feel like we've been very successful in this work. We've reached over 159 participants between all those activities that I've mentioned, between the rally and the workshops and the interest group. As a part of that, we've also reached a number of different organizations, including health systems and clinics, as well as those clinics and organizations serving those populations with high tobacco use rates. So this is really exciting. One of the other things that we are working to do is really building the momentum and energy around health systems change in Minnesota on tobacco. And so we are working closely with the grantees to tell our story, and this has been really successful in building that reach as well as building that momentum. So the grantees have done a great job at presenting at various conferences, and so we really are looking forward to continuing to share all of these efforts and their stories. So with that, I think I did go over a little bit over time. I apologize for that, and I'm going to turn it back over to Ann.
Great. Thank you so much, Megan. That was great, and thank you again, Joy. And so just to remind everybody, if you've got questions, please feel free to put them in the Q&A box, and we will get to them. But as the moderator, I'm going to take the moderator's prerogative and ask the question of both Joy and Megan. And the question is, you guys have both done a lot of work with different health systems in your states. And so my question is, what do you know now that you wish you had known when you had started working with these health systems?
Wow, that's a really good question.
This is Megan. So it is a great question, and I think that you know, one of the things that I found, and Joy, you alluded to this in your presentation, is again how this really takes a lot of time. It can take time and patience, and just having the true flexibility with these initiatives is really important. And so just knowing that how important that is going to be as a part of working through and supporting and providing technical assistance to these, to these organizations and health systems doing this work, and recognizing that I think is really, really key. So the flexibility is pretty huge, and that as a funder for us, that meant acknowledging that there would be shifts in either the objectives or goals throughout the 2-year period, because again, systems are different, things change, things get prioritized differently, or there's opportunities that we want to take advantage of. And that happened for a few of our grantees. So just having that flexibility, I think, is very key.
I would have to agree with that, Megan. Those probably are some of the key issues. You know, when we talk about the difference in systems with large systems that have clinics or small hospitals in rural areas, every system truly is different. And I think, as you said, time and flexibility, you know, we're able to provide a generalized knowledge and guidance of implementation of the content. You know, we do training of staff and all of that. But we're very clear when we work with them on developing an implementation team in the hospital to help them understand that this will take some time, particularly if they're doing an EMR build, and just understanding that it's their job to work with us to fit it into their system. So it has to work in their system. If it's not going to be user-friendly in their system, then it's never going to work. And so it's a true partnership in working on that together. And I think the other lesson that we've learned, because we've carved this as we've gone along for the last 8 years, is that when you have especially big systems, it really takes resources. It's very difficult for large systems just to assign it to someone that's a staff member because it falls down on the priority list. So we learned with our first big system that we would subcontract for up to 3 years to pay half of a position and to match them on that so that they would have some investment, but we also have a little bit of control through that subcontract to work with that coordinator internally with the hope that the hospital will sustain that position later on and keep some focus to it.
Great, thank you. We've got a few questions that came in, and we'll try to answer them, and if we can't get to them, I promise we will try to get you guys answers to those questions. So we've got one question from a name I cannot pronounce. So it's going to be, what has worked well to, 1, educate clinicians, and 2, to evaluate how well a practice is doing and to set goals for improvement? So what's worked well to educate clinicians, and what's worked well to evaluate how a practice or a hospital system is doing, and then set their goals for improvement. Do either of you have experience with that?
This is Megan. I can speak to that a little bit. With our grantees and even thinking about our capacity building project, I think the one thing that has worked well to educate clinicians, and again, some of this comes from the experience from the grantees, but also with working with various health systems and kind of engaging them, it's really meeting the health systems where they're at with this work and really trying to think of what is the information that physicians feel like they need. So one of the things that we found that they really do realize they want is information on the nicotine replacement therapy, as well as information on scripting and how to talk to patients. It can be very simple, but in a sense, some physicians aren't comfortable. They don't feel like they know that information or have that information. So being able to start there and really just share that has been really successful. I know that our grantees also thought about ways to really engage their providers by thinking about other issues that might be of interest to the physicians and bringing tobacco along. So, for example, e-cigarettes was kind of a hot topic for a particular clinic or health system, so they would start there and share information on that, but then they would transition to other pieces around tobacco, the importance of addressing tobacco and assessing for it and what that looks like. And then, so again, thinking about those other topic interests or whatnot, I think is important. And then to the second question of evaluating how well the practice is doing and then setting goals for improvement, I think that's really challenging because, again, I think it's going to be really dependent on the health system and where they're at and what their current ability is. So one thing with the electronic health records, obviously the key there is it's a really great tool to start, to track the efforts. But for some of our grantees, they didn't have that in place prior to their project. So they've been able to, setting a goal was a little more challenging because they didn't have a great baseline. But now that they have the information and they're starting to track that, they can, determine what their goal might be. And I think it's also important to think about, especially with a health system that's like large and integrated, there may be multiple clinics and they may have different clinic goals based on what those needs are. Some of the grantees base some of those goals on trying to meet other measures, such as diabetes measure or other things that they were looking to try to reach, and realizing that tobacco is hindering those measures, and then pointing that out to providers and using that as a way to incentivize the providers, so getting to that first question as well as the second one. I hope that helps.
Yeah, great. Thanks, Megan. And it looks like, unfortunately, we're out of time, but we will get a copy of the questions, and I promise I will try to get answers or tell you that we don't have answers to them if we don't. So thank you again so much, everyone, for joining today's webinar. My contact information is right here. And please feel free to reach out if you have any questions or concerns. We will get a copy of the correct copy of the slides out to everyone, and we will have a recording of this webinar in case your colleagues were unable to make it. So I just want to thank you again for joining us, and again, thank our wonderful speakers, Joy and Megan, for participating and presenting on their great work. So thank you all so much, and we look forward to talking with you soon.
Thank you. Thank you.
This does conclude today's program. Thank you for your participation. You may disconnect at any time.